This is Shahzad Ahmed presenting a video for a comprehensive history taking. This video will help the undergraduate medical students who are just entering their clinical rotations, as well as the graduate and postgraduate students who are preparing for their clinical exams. History taking is the first step in the interaction between a doctor and a patient. It is an art in the field of medical science which integrates the basic and clinical knowledge to make a final diagnosis. It's not merely a question and answer session with the patient. Instead, it is a scientific approach toward the patient's complaints which directs the further plan regarding the investigations and treatment of the patient. The first step in history taking is to collect the patient's basic data, which includes his or her name, age of the patient, gender, marital status, religion of the patient, occupation of the patient, and then we come to the mode of presentation as well as the date and time of presentation. After that, we have to construct a presenting complaint. The presenting complaint is the most recent problem which has led the patient to seek medical attention. It has two parts: the complaint itself as well as its duration. After determining the presenting complaint or the complaints, we have to determine the chronological order of the complaints if there are more than one presenting complaints. Here is the point where we have to construct a differential diagnosis to direct further history taking. And in order to take a comprehensive history, one must know the presenting features of the most likely diseases coming in the list of differential diagnosis, the diagnostic procedures involved and the complications related to each procedure, and the treatment options and the risks related to each treatment. For example, we will elaborate the history taking with the complaint chest pain for 1 day. And when the patient's presenting complaint is chest pain for 1 day, then the differential diagnosis at this stage will be angina or myocardial infarction, aortic dissection, pulmonary embolism, pneumothorax, pneumonia, muscular chest pain caused by trauma or costochondritis, skin problem or infections like herpes, or a panic attack. After constructing a presenting complaint, then there is history of presenting illness. It has 4 different parts. The first part is the evaluation of the presenting complaint itself as well as its associated features, which will likely lead to the most likely diagnosis. The second part is to rule out the differential diagnosis, and the third part is to evaluate whether any treatment or intervention has been done so far and the result or outcome of that treatment or intervention. And the fourth part is the systemic review. Now we will discuss all these segments one by one. So keeping the presenting complaint as the chest pain for 1 day, we will at first evaluate the chest pain itself, its site, its onset, whether it is sudden or gradual in onset, its duration, its severity, whether it is mild, moderate or severe in intensity, its character and its radiation or referral to any other part of the body, as well as its aggravating or relieving factors, such as whether it is relieved or aggravated by breathing, movements, and whether the pain is relieved or aggravated by manual pressure at the site of pain, whether it is relieved or aggravated by food intake, walking, sitting, lying, taking sublingual nitroglycerin tablet, or any other factors which are narrated by the patient. And then we have to evaluate its associated symptoms such as sweating, vomiting, dizziness, or temporary loss of consciousness. The second step in history of present illness is to rule out the differential diagnosis. And here we will have a set of questions which will rule out the differential diagnosis one by one. For example, when we ask about the chest backache along with chest pain, we are meant to rule out the aortic dissection, because the pain of aortic dissection often radiates to interscapular region. Then we will ask about shortness of breath, or blood in sputum, or a history of surgery or fracture in the recent past, or a history of cancer. All these 4 questions are meant to rule out the possibility of pulmonary embolism. Then we will ask about fever or cough associated with chest pain, and if it is present, it will point towards pneumonia. And then we will ask about eruption or any rash over the chest wall, which will point towards herpes zoster infection. And then history of recent trauma, which will point toward muscular chest pain, as well as tingling sensation of hands and feet. The presence of tingling sensation of hands and feet will point towards most likely a panic attack. Then the third step in the history of present illness is to evaluate about any treatment or intervention done so far. And for that, we will ask the question about whether the patient has visited any clinic or hospital, and whether any treatment has been given, and what was its effect, whether the symptoms were relieved, if yes, for how much time. And we will ask particular questions about thrombolytic therapy. And as we know that many centers nowadays offer primary PCI for acute myocardial infarction, we have to ask about angiography, whether it has been done or not, and we have to ask the relevant questions to elicit the answer if the patient is unable to understand the word angiography. Then we will ask about the history of development of shortness of breath during the course of treatment, or any history of chest compressions or electric shock if the patient narrates that. Then the fourth step in the history of present illness is the rapid systemic review. For that, we will have a set of questions rapidly going through every system of the body, such as asking about headache, vision disturbances, hearing disturbances, difficulty in speech or swallowing, weakness of any limb or side of the body, abdominal pain, constipation, loose stools or blood in stool, blood or pus in urine, joint pain or swelling, bluish discoloration of fingers, and pain in legs during walking. Here we complete the history of present illness. The next step in history taking is to elicit a detailed past history, which will include the history of any similar episodes in the past, or any investigations done in the past, prior history of coronary angiography or percutaneous coronary intervention, whether it has been done or not. If it has been done, then we have to ask further questions about it, that when it was done, what was the route of access, whether it was radial or femoral, what was the result if the patient is knowing it, and whether the patient developed shortness of breath, chest pain, or weakness of any side of the body during or after the procedure, excessive bleeding from the access side, blood pressure drop during or after the procedure, and decreased urine output after the procedure. All these questions in the last point out toward the procedural complications. and then we have to elicit the prior history of coronary artery bypass surgery, about the history of prior CVA, and any other significant event in the past. At this point, I will again make you to remember that we are eliciting this history and asking all these questions, keeping in mind that the patient's presenting complaint is chest pain for 1 day. The next step in history taking is to elicit a detailed personal history, which will include questions about comorbidities, such as in the case of ischemic heart disease, the comorbidities are diabetes mellitus, hypertension, or dyslipidemia. And if any one of these is present, we have to ask further questions about these entities: when it was diagnosed, when was it treatment started, and what was the treatment given, and what was the compliance to the treatment, and what was the control of the disease with that treatment. And then questions related to complications of the long-standing comorbid conditions. Here we suppose that the patient is non-diabetic for last 10 years. Then we will have to ask about its complications, whether the patient is having visual impairment, early satiety, postural blood pressure drop, sensory or motor weakness. And a detailed personal history will also include the history of smoking. If the patient is a smoker, we have to determine the pack years. And the personal history will also include whether the patient is married and the number of children. The next step in history taking is a detailed family history, which will include the history of ischemic heart disease in first degree relatives, as well as the history of dyslipidemia in first degree relatives. Next we come to the socio-economic history, which will include the monthly income roughly, as well as the insurance status of the patient. Next is the drug history. It will include any type of drug that the patient is taking and the history of allergic reaction to any medicines in the past. If the patient is female, the menstrual history is very much important, because many menstrual as well as pregnancy related problems are now known to increase the risk of ischemic heart disease. The menstrual history will include the history of menstrual irregularities in young females, or the history of menopause in older females, or the history of CVS related complications during pregnancy, such as pregnancy-induced hypertension, preeclampsia, or eclampsia. Here we conclude all the steps of a detailed and comprehensive history taking. I hope this video will help the target audience. Thank you very much.